Welcome, everybody. We're going to give a little time for people, especially people on the West Coast that are finishing up their office hours to jump on. We have a good number of people that registered for the webinar, and we don't want to keep people too late, but we want to make sure we don't start too quickly. Quickly, we'll just introduce Danielle Ledoux, currently chairing the Socioeconomic Committee, Hawk Yoon, Vice Chair of the Socioeconomic Committee, Heather Marjeski, the Vice Administrative Chair of the Socioeconomic Committee. And we have a few things to go through, a few examples of how to use the grid and really where did the grid come from, which we'll dive into a little deeper in just a moment. Heather, you give me the thumbs up when you feel like we have enough participants to start.
Yep, we'll just give it one more minute. Grab your coffee, grab your tea. All right. Well, thank you everyone for coming this evening. As Dr. Ledoux said, we are members of the Socioeconomic Committee. We can't wait to get this webinar started and go over the new MDM grid that we're presenting tonight. A few notes of order. We are on Zoom. We are not using the chat tonight. So if you have questions as Dr. Ledoux and Dr. Yoon go through things, please put them in the Q&A. We are going to try to respond as best we can. If we don't get to your question, know that they're all saved and that we will be responding afterwards if possible. The webinar is going to be recorded. It will be sent out to AAPOS members following the completion in the next couple of days. And if you do have any further questions on the MDM grid or the other great things the SEC committee is doing, consider emailing us at info@apos.org. And with that, Dr. Ledoux, it is all yours.
All right. So we want to really focus on the medical decision-making element of pediatric ophthalmology. So last year, the AAPOS Socioeconomic Committee decided to build a grid out that would reflect the things that we do every day when we're caring for patients. These are the three people you're looking at. We are currently the leadership team for the Socioeconomic Committee, and there are financial disclosures. And this is our current socioeconomic committee. So last year, a good amount of the work was done to develop this appropriately. And there are members that are left off of this list that were active participants. But we also worked with a broader membership. So we did focus groups both at our annual meeting last year at AAPOS as well as by Zoom, with the goal to really represent the members nationally and how best to use this in a way that we all feel is meaningful for what we do every day. This was supported by Christy Morse, by Sean Donahue, David Hunter, Barry Wasserman, Gil Binnenbaum, and approved by the AAPOS Board of Directors, who really kind of helped along the way with continuing to encourage this to completion. Kevin Corcoran was absolutely indispensable in advising us through this process. So as we would take this to different focus groups or work with it within the committee, we would make alterations to the grid and we would go back and we would work with Kevin to review it. Ultimately, after we had a completed grid working with many different people from AAPOS, Dr. Repka also reviewed, and really he was the initial supporter and helped to make the connection with Kevin Corcoran. But we must thank Dr. Lance Siegel, who had the foundational draft that really was the initial mastermind behind all of this. So billing and coding is pretty controversial. And our goal was not to decide, the three of us sitting here, what is most important for pediatric ophthalmology care. It was to build consensus amongst a representative group of us within the membership. We want to now lay out how to use this grid, which is available on the AAPOS website. Ultimately, when you are seeing a patient, caring for them and understand what you are embarking upon, your medical decision-making is your own. And while we think we're amazing, we're not professional coders. And so we want questions to come our way. We want to understand if there's areas of confusion that we can help to shed some light of clarity on. But ultimately, of course, when you code, the coding is your own. So again, as Heather had mentioned, info@apos.org is a great way to get some questions to us. And we are going to take a lot of what we get both from tonight and from emails from all of you to try to also advise how we'll present this at the annual meeting at AAPOS in Boston in 2026, March of 2026. This is a reference to a fact sheet that came out. The American Academy of Ophthalmology worked with some members of AAPOS to develop pediatric ophthalmology specific cases and how coding could be used along the way of managing those. And you can see those 6 cases down to the bottom of the slide. You certainly are welcome to scan this QR code in order to link to this resource, which is extremely helpful and also works complementary to what we are presenting. I believe Heather also put into the chat a few resources for you, one being the MDM grid, which is available or will be available on the AAPOS website and was also downloadable from when you registered for this. The second is to deal with downcoding. So downcoding is happening, unfortunately, automatic. AI is actually downcoding a lot of what we are submitting. And so when you know you have coded something correctly, she has provided us with a template that you can use to argue it. And then lastly, this fact sheet from the Academy. So our agenda here is really to discuss how we got here. So what is it? How did we get here? And how can we use this? So we'll give you some examples, and certainly more could come. And again, what you find as questions along the way, those are ways that we can help to develop maybe even a resource that would be, again, available on the AAPOS website with some examples of appropriate coding. So to jump into what the medical decision-making grid is, this is the 2021 version that the AMA put out. So this is the first major revision that was done to the E&M codes in decades and decades. You can see that the level of coding is listed along the left-hand side, and the columns across the top are the number and complexity of problems addressed. The elements are the reviewed or analyzed data in the middle column, and then the risk of complications and morbidity and mortality of patient management along the far right column. The Academy took this revised 2021 guide and helped to make it more tangible or understandable for ophthalmologists in general. They changed the layout. So here you can see that actually their columns are the level of coding. So from level 2 to level 5. And then the left-hand side is again, those 3 top columns in the AMA grid. The focus here is for all of the subspecialties within ophthalmology. And I think sometimes these grids are both cumbersome to deal with and don't always feel they exactly apply to what we do as pediatric ophthalmologists. And so we took a version of this grid, again, looking more like the original AMA revised coding grid, and looked again at these individual columns, but with a focus on the things that we may more often do. And so we'll kind of try to walk through how to use this and specifically where some of our common cases might fall. This is a 3-page, when you download it, it's 3 pages. So if you look here along the left-hand side here for terms, these terms are going to fall within the number and complexity of problems addressed. Some things aren't word for word recognized in these columns. So for instance, here we have a chronic illness with exacerbation, progression, or side effects of treatment. In essence, this would fall into something more along the lines of, a chronic illness that is new or worse, as opposed to a chronic illness with severe exacerbation, which is again represented on page 2, a little farther down. We provided examples within each one of these that may fit, and of course it's not exhaustive, but we wanted an idea of where different types of diagnoses or situations might fit. And then this is the 3rd page of the guide, and this is really to look at probable CPT coding level. And so we'll use this again in some of the examples. No one patient will ever fit correctly or exactly each time that you code them. And so you know what makes that visit or that situation with that patient a little different and what's an appropriate level of coding. But we wanted to provide some examples of things that we commonly see to give a probable level of coding based on what was assumed, to be the risk per the membership. We also kept a few of the social determinants of health listed directly on this too for easy access. All right, so starting with the first example. So this is a failed spot vision screener. You have a 1-year-old whose family had some concerns, and so they were screened using the spot at their pediatrician's office. Mom had been noticing that she seemed to bring objects close to her face and was squinting, and thought she was a little clumsier than her other kids. She thought perhaps the left eye was turning in sometimes when she was eating or concentrating on something, but that seems a little better, and she developmentally has no other concerns about the child. So on your exam, she had central steady and maintained vision in both eyes. You did get a teller acuity test, both eyes open. Her eyes were well aligned, both before and after dilation. And her cycloplegic refraction was a +675 in the right eye and a +775 in the left eye, the eye that mom thinks sometimes she sees turning. The remainder of her exam was normal. So when we use the MDM grid for this, we first think about the number and complexity of the problems addressed. So this child has amblyogenic levels of refractive error. Maybe even many of us would say has refractive amblyopia, and she has high hyperopia. As far as what you had access to at the time of your visit, for the middle column, this would qualify for an independent historian for the elements of medical decision-making. So mom is providing you with the history. You didn't have a copy of a pediatrician's note. You didn't have a copy of the spot. But you did recommend glasses for this child because of your concern of amblyopia. So if we look at our 2 diagnoses, bilateral refractive amblyopia and high hyperopia, your plan for the child, which is glasses full time, warning mom that she may start to see the eyes crossing when the glasses are off. You made a decision to reduce the full plus with the concern, of course, that the child could end up crossing. And so you want to have them follow up in the near future for alignment and vision testing. So this would be coded as a 99204. She's got 2 new but chronic illnesses. She has an independent historian, and you've prescribed glasses for the treatment of her amblyopia. And if you see on the 3rd page of the grid, specifically amblyopia or amblyogenic risk factors requiring eyeglass prescription is listed at the level 4. And that's purposeful, that this grid serves as a potential way that if for some reason you are found to be downcoded, you can provide this grid, this AAPOS approved grid, to help with the claim. I'm going to pause for just a second and Heather, just see if there's anything you'd like to add in there.
No, I think that's fantastic. There was a question regarding direction that the AAO coders have provided previously, and we recognize that those recommendations were made earlier. This grid expounds on a bit of those and was really focused on our specific specialty and how we treat diagnoses. So you'll notice we're very specific kind of with our examples, and I'm sure Kevin Corcoran will provide us some more guidance. But do know that this has been reviewed by those pieces of the Academy. And so while they don't have it specifically highlighted that it is an Academy approved document, we have gotten the blessing of all of the important people at the Academy for that. And our really important AAPOS board has approved it.
All right, so I'll move on to a second example. This photo is stolen from one of the academic centers that had it posted, but it's a lovely example of a child with accommodative esotropia. So this is a 5-year-old in your office who did have surgery with you as an infant for infantile exotropia, had been well aligned for years, over time developed an accommodative esotropia, and has been in glasses since. He's here for his regular follow-up, accompanied by his mother, who reports that when she's with him, he wears the glasses full time, but she's concerned that when he's with his father, that he is not. She wants to be sure that our office note reiterates how often the child should be wearing the glasses. She makes sure to let us know that he's had a new RX since the last visit, and that they keep working with the optical shop to make sure that the glasses fit appropriately. There's a strap on the glasses, but yet when mom sees him by FaceTime, either the glasses seem to be too loose, too tight, the patient's nose is red when he comes home, and so she's trying to find a way to get them to fit better. When the glasses are off, mom sees that the eyes are crossing, but she feels apart from that the misalignment is essentially the same since last visit. So you can see the vision in the right eye is 20/25, similar to your last visit with him. The left eye is 20/30, maybe a little worse than the last visit. No recorded stereopsis, but this was true as well at the last visit. And there was fusion both at distance and near in the glasses, same as at prior visits. The alignment in the glasses is quite good. So small angle strabismus, non-manifest associated vertical deviations, but when the glasses are off, increased crossing with particularly at near apparent strabismus. The current glasses prescription matches the last cycloplegic refraction, which was done about 8 months prior, and the remainder of the exam was within normal limits, although he was noted to be intermittently looking over the tops of the glasses. So you have multiple diagnoses for this child who you have had to operate on in the past. So he does have a well-controlled accommodative esotropia when he is using the glasses, but there is a suspicion that there's incomplete use of them. He has still moderate hyperopia for which he's in his full cycloplegic refraction, but perhaps the most difficult element of this management really has to do with the fact that this is a split family. So that has a Z code related to the social determinants of health, where medication and treatment plans may not be carried out by both parents. So your plan for the child is to continue in glasses full time, and the discussion around that involves dad by phone and mom in person, during which time they continue to argue in front of you and the child about whether the glasses are being used consistently and why not. And dad also wants to be sure he knows that vision therapy is an option. You want to see him back in the near future. You are going to repeat the cycloplegic refraction, update the glasses accordingly. So you really have 2 chronic illnesses or more really here. You have an independent historian, but the sort of most highlighted element of this case is that the diagnosis or treatment is significantly limited by the social determinants of health. And this has to be in your documentation. So while we may not find these particular codes to be covered by insurance companies, the fact that we are having these interactions that are complicating the care of the patient. So this is a child who's been operated once before, could head in a direction that you wouldn't want, an unstable direction, because they're not adequately using the glasses that otherwise would treat the underlying condition. So whether this is stable or not, whether this is a new or worse chronic illness, we could discuss further. You know you have an independent historian, but between what you have in the number and complexity of problems addressed and the treatment that's being limited by social determinants of health, this meets the criteria for a level 4. So we have 2, this is page 2 of the grid, again, kind of highlighting where would our diagnoses fall within this list, and how do we think about the definition of it. So chronic illness getting worse, not controlled, or progressing with an intent to control progression that will require additional care, versus someone in a stable situation. I'm going to pause again for a moment. I'd like to sort of highlight that these are 2 selected examples where really your middle column to do with data management was largely elevated based on having an independent historian. This is in part, how many of us practice. Some of us are in hospital settings, some of us are on Epic, and we have access to a lot of data, but often a lot of our practices don't involve as much data, and that middle column might be the area that we as ophthalmologists often find harder to really say that we're coding at that level. Heather, before I move on, do you have anything you want me to? No. Okay. Good. All right. So retinopathy of prematurity is something that we spent quite a lot of time talking about in the focus groups with Kevin Corcoran, ultimately with Dr. Rebka. So we're going to start with the example of a baby that was born at 25 and 6, birth weight of 825 grams. Currently, when you see them, the age is 37 and 47. Last exam was 2 weeks prior when it was zone 2, stage 0. On your exam, you see zone 2, stage 1. So for recommended follow-up in that period of time, the child got discharged from the NICU and came back to your office at 38 and 4. You noted on your dilated eye exam, the child now is zone 2, stage 2 in both eyes. No significant change at that time to the posterior pole vessels. You had nice dilation, normal anterior segment exam. So you recommended follow-up in 1 week because of the progression. So let's discuss how we code both the inpatient and the outpatient exams. So again, without even having to focus on the middle column to talk about data management, you have a acute or chronic illness or injury that poses a threat to life, bodily function, sight that is emergent. And you can see that we added in the right-sided column, retinal condition requiring intensive monitoring. So while this child also has certain risks at the time that they're within the hospital, they're hospitalized because of their prematurity and their young age and vulnerability. You also have a condition that is progressing that you are monitoring and having to follow up quite quickly. If you look at the second page, we defined acute or chronic illness or injury that poses a threat to life or bodily function as anything that was stage 1 ROP or worse. Whereas an immature retina, still during the nursery period, would be an acute, uncomplicated illness or injury that did require a hospital inpatient or observation level of care, which again is related to their prematurity. I'm going to pause again, and Heather just checking in to see if there's any questions that we should go over.
Still good.
Okay. So example 4 is a child that is currently on Plaquenil, here for their annual exam. So this 15-year-old has been on the Plaquenil for the past 3 years. Their review of systems is negative for any kidney issues. Her current weight is 105 pounds. Her current height is 5'2". Her current dosage is 200 milligrams per day. She's seeing you twice a year, separating out the yearly eye exams from the yearly testing. So she will have updated dilated eye exam, including a nearsighted prescription, as well as testing on the opposite 6 months. So when we think about how to use this grid specifically for this child, we know that there's 2 or more stable chronic illnesses that they have. Depending upon what I've presented for data, what you have accompanying her is a parent who's going to give the history. There may be times when you have been reached out to by the rheumatologist, or where there may be specific things that you are reviewing about this child's health history in your medical record system. And I think that's especially true for those of us that have a shared medical record system with some of the other specialties. But for a lot of these patients, we know the risk is fairly low, but not 0. And so we are taking a look at what is available to us based on what we have to do, or in this case, maybe don't have to do for the child. So she's going to be given an updated eyeglass prescription for her myopia, and she has ultimately a normal exam. And so while, ordering of each unique test might feel like this fits, in fact, most of the tests that you ordered, such as the OCT, or the visual field, are likely ones that are being done in your office. And we aren't ourselves prescribing the Plaquenil. And so our risk level or our level of coding doesn't, by what we have in this example, hit a level 4. These are stable chronic illnesses. So this is sort of where on this grid it would fit in. And we bring this example up because if we were to go by E&M, at least with the information provided, it really would be a 99213. And we are also able to benefit from the fact that we have a list of I-codes that can be used, and our I-code, the rules behind coding or using the I-codes have not been updated in any way. And so all the rules that you know or times when to use it still apply. All right. I'm going to move on to the last example. And then when we complete this, I think we'll just take the rest of the time for the three of us to discuss what's come in through the question section. And again, everything that people have for questions, confusion, when they start to use the grid, if there's things that need clarification, info@apos.org, please, so that we can help to make a more robust session when we introduce this at the Academy, at the AAPOS meeting in March, and also for us to try to develop some examples that can serve as a downloadable resource. Okay, so this is a child with a leukochoric reflex. She's 3 days old when she's seen in your office, brought by her family. The neonatologist at birth had detected the dull red reflex and had reached out to you regarding the need to see the patient urgently. So the appointment was made prior to discharge from the hospital. You reviewed the discharge summary. There was nothing too concerning. The child did have IUGR during pregnancy. There was some intrauterine exposure, clonidine and Prozac. The exam was normal at birth with the exception of the dull red reflex. The baby was born full term. On your exam, she blinks to light in each eye, has an eye-popping reflex when the light was dimmed, and she was awake. She had no relative afferent pupillary defect. You did not see nystagmus, perhaps intermittent esotropia, but again, the child was largely asleep. The eye may have been slightly smaller on the right, and you could see only a cataract through the non-dilated pupil. Through a dilated pupil, it seemed to be 5 millimeters, perhaps larger and central, precluding a good view to the fundus. The left eye was normal. B-scan on the right was negative, no detectable stalk, and there was nothing abnormal appreciated of the macula. So your impression, this is leukocoria secondary to cataract, central cataract with possible microphthalmia. So you have a plan to remove this cataract at 4 to 6 weeks of life. No placement of the IOL based on IATS. Aphakic contact lenses were discussed with the family. We want to do a little bit of a further look at the size of the eye at the time of surgery based on the possibility of microphthalmia. So these risks, benefits, and alternatives to surgery were discussed with the family, and consent was signed for cataract surgery. So this would be a level 5, 99205, because you have one or more illness with a severe exacerbation. You did discuss this with an outside provider when the neonatologist contacted you. You also reviewed outside records. But the big element here too is that this is elective surgery with identifiable risk factors based on the patient's age. So when we look at page 1 of our grid, again, we have an urgent situation, a chronic illness with severe exacerbation, and that would require major surgery within the critical period for this child. If we were to try to really look at a level 5 amongst data, you can see you need to hit 2 out of 3 categories. So category 1 is a mixture of different data management elements. Category 2 is you interpreting independent tests. And category 3 is discussion management. And so even if you reach back out to the neonatologist, that element would be a level 4. You would have to hit and complete 2 of these other categories in order for that middle column to be a level 5. So again, this chronic illness with severe exacerbation, significant risk of morbidity without treatment, and they may require hospital care or escalation of care. And so we see congenital cataract requiring treatment within the critical period is listed in this category. And also here on probable CPT coding level based on risk. All right, so QR codes, again, also these are all available within the chat that Heather had left for us. And so please feel free to scan them. I'm just going to leave this slide up, and then I'd like to just open up for us to discuss a little these cases and any other questions that have come in. Heather and Hawk, you want to join?
Or
Yeah, I think there were a couple of RP questions. We will, correct me if I'm wrong, Danielle, this is being recorded, so you can go back and look at this in the slide deck per se in that manner. I think there are a lot of specific coding questions that are coming in. I think we want to stress that we are not coders per se. This is the MDM, I think, is really meant to be a support document and not a how to do everything. Um, but yeah, I think we're going to hold off maybe on answering a lot of the very specific coding questions and maybe try to keep this at a more philosophical level about the grid. But um, for the ROP question, and there's a corollary question about was consider intensive monitoring. So that has to be, I think, if correct me if I'm wrong, about every you have to look at something at least every 3 months. That's like it's something that has to be checked very often, and certainly weekly or biweekly meets that criteria.
So when we discussed this, and we went back and forth for weeks, if not months, about what do certain terms mean. And when it comes to a level 5 for intensive monitoring, this is like life critical monitoring, right? So you're monitoring every few hours, for some, it would be like every few minutes. It really has to do with the imminent danger that the patient is in and what that risk means. So, the advice we have received from the professional coders is that a lot of what we do isn't really qualifying under that intent of the term. And so that's where certain things like some of the ROP, we would think, well, all ROP falls in there. That's intensive for us. But really the spirit of the code across all of medical coding and decision making is really life critically monitoring a patient.
So what we especially kind of focused in on by adding in that terminology is things like retinopathy of prematurity. So, children that you are very concerned are progressing as you're following them. Children with retinoblastoma who need pretty intensive monitoring for new tumors. That was the spirit of adding that in to that column. And in support of the work that we all are doing with ROP, which is probably its own unique risk, as I feel Kevin said, that may not really fit on a 5-level grid, but it's something that we do, and we know that we're doing better by our patients for it, but we are trying to lend support to the process.
So we have a couple questions. One of them was that discussion around prescription glasses or contacts as moderate risk. And so I'm going to let Danielle and Hawk correct me if I'm wrong, but really that concept of the glasses prescription is correcting the diagnosis is where you're looking at for that. So putting a child in glasses that is straightening their alignment is considered that part of the prescription, which is different than myopia, which is not necessarily considered a medical diagnosis in the billing world. But Danielle and Hawk, correct me if I'm wrong or expand.
Yeah, so it's treatment of the disease. And so when you're seeing the child that has, amblyogenic levels of refractive error, or they have bilateral refractive amblyopia, and you're modifying the glasses because there's been a significant change which you think is contributing to the amblyopia, perhaps a reason for resistance to treatment of the amblyopia. Or a good example, like you said, Heather, if you've got a child with strabismic amblyopia, you need to straighten their eyes with the glasses. They need to be wearing the glasses in addition to ultimately initiating treatment, perhaps beyond just glasses alone. And so the thought is new or worse implies you have not gotten to your treatment goal. So you have a child that presents with eye crossing, presumed or known amblyopia, and you continue to work towards straightening their eyes and treating their amblyopia, but you have not hit your treatment goal or they're progressing despite it, which could have multitude of reasons, such as, for instance, the example that was given tonight, but also maybe that you're co-managing two problems and have to continue to manage them in different manners, such as ultimately doing strabismus surgery for a partially accommodative, as well as continuing to patch to improve amblyopia. So that's the kind of glasses prescription we're talking about, modifying it in order to treat those underlying diagnoses, a little different than the myopia prescription that you're providing the child from the Plaquenil example.
And we have some questions just to go over. What does with identified risk factors mean?
So the best examples to kind of give in thinking about what are identifiable risk factors. So you have the child in your office that's got achalasia, treated for preseptal, let's say, that's resolved, chalasia is not going away, the parents want to excise it, you agree, but you can't do it in your office. The identifiable risk factor is it's a minor problem, but it's going to have to go to the operating room because of their age and lack of cooperation. So that's a minor with risk factors. The other way of looking at that is once you have to give the child general anesthesia, that is kind of major elective surgery now, even if it is for a problem that might otherwise have been viewed as minor. Similarly, thinking about the child that you have a hard time getting, you have decreased vision, you're having a really hard time getting an adequate exam, and you deem that they need to have an exam under anesthesia because you're concerned sufficiently, or you're accepting some level of risk because you can't be certain that you didn't miss something. So the child, documenting that the child has autism or some types of delays that are precluding you getting full information, those could be identifiable risk factors. A person that you take that you recommend for strabismus surgery, but ultimately something about their health condition requires them to be done in a hospital setting, maybe their BMI or their risk factors of their multiple different diagnoses that don't allow you to operate them in a typical situation for you in a typical location that you would, but requires a different level of care. Those are some examples. And in age alone isn't necessarily an identifiable risk factor, but certainly in the instance of the young baby, the age is a real consideration, both the timing, how quickly you have to book that child, and the setting in which you have to do that child, given they were 4 to 6 weeks of age. So then in that case, that would be an identifiable risk factor.
Mm-hmm.
Any other thoughts, Heather or Hawk?
Well said.
I'm just going through your questions here. Good doctors. Let's see here. There are quite a few different questions about different conditions or different diagnoses and where would they fall on the grid. Some of them we couldn't find a lot of consensus, I'll be honest. And then there's the ones that are on the grid where we had a lot of consensus over all of our different focus groups and different interests that we discussed with everyone. So we are going to take those. We're not ignoring you. We just want to make sure we give you the right information to come back with. So if you don't hear from us tonight for that, you will hear from us as we go on.
Just to kind of go back to this element, some of the descriptors here are really designed. Obviously, it's not an exhaustive list. And so some of the descriptors in this middle column are really to allow you to think about the diagnosis that your patient has and which particular category or term best applies, or if there's multiple diagnoses, how to determine that.
I think the other way to look at this grid is not, again, to tell us how to code every single scenario per se. But this goes back to the templated down-coded denial letter. I think as the AAPOS SEC committee has kind of looked at this, we wanted to give the body support as they go back to their billing or coding and insurance companies and say, hey, this has been approved by AAPOS. We have the backing of AAPOS. This is our support document, and therefore this is the logic that we're applying to this. And certainly, as we look philosophically, certainly the AAO has done a great job of coming out with their grid, but it's not PED specific, and that's really what we were trying to do, and give you as many scenarios and guidance as possible, but without trying to be exhaustive. We don't want to, in a part that philosophically, we don't also want to box you in. We don't want to say, oh, we did everything and then you're locked in. This is a guide. You will take this and use it, hopefully as you see fit, to your particular situations. This is not to say this is exactly how you should do it, period.
And we do have a few questions about the down-coded template letter and relative success with it. So remember that for the vast majority of these claims, the people who are going to manually deliberate your appeal have no idea what you do as physicians. And so they're really going to go based on what is in the note and what says in their policy guide for better or for worse. So I personally have had quite a bit of success. While AAPOS hasn't necessarily gone through down coding for the last 6 months, Oculoplastics has. And so we fought every single one that was inappropriately down coded and have won 98% of them. There were a couple we didn't fight because the documentation wasn't super clear, and that is a learning experience for our office. But in the end, I urge you to fight the good fight. You did this level of coding. You saw this patient with this level of risk. You deserve to be paid appropriately. And so it is going to be more work for your billing department. It will probably be a bit more work for you if you're in independent practice. But I would not let them take this type of, reimbursement in mass away from you from a sweeping new system requirement that they've put in.
And it's something that's happening across the board. I mean, all physicians specialties are reporting it. I had something from the AAP in a blast today about this automatic downcoding that's happening via AI. And so it's real. And you do the job that you do. You treat the patient as you should. There's support here for decision making within the coding realm. And then really it's just a matter of fighting the down codes or fighting the denials appropriately. So this is the intent of this resource. This does not provide all the answers. I am looking at a lot of the questions that are here, and some of these questions actually can be answered even within looking a little bit more carefully at the grid itself, but we will still try to pick out ones that people found were particularly important that are more specific coding questions here, and try to dive into it more. We didn't get into prescription drug management either, but of course, anytime you write a prescription for a drug, that is its own level of coding. That's been somewhat clear from the AMA to the AAO to AAPOS, all of these grids.
We have an anonymous question that says, does insurance recognize the AAPOS suggestions? The insurance companies are supposed to go with the consensus of the specialty. So by us and AAPOS approving this grid, that is one of the things we are hoping happens, is that you can cite the grid and say, this is what the preponderance of my subspecialty believe, to be true based on their years of medical experience. And so we're hoping that it's a piece that you can use in that fight and that they will recognize it. Will they automatically? I can't tell you what private insurances will do. I've seen it all. But that's a great question. And does AAPOS plan to hold coding camps specific to peds ophthalmology similar to the academy? Right now, we are going to present on this grid again at the annual meeting. And if I had my hopes and dreams, Dr. Morris is on this, I'm sure she'll know, maybe one day, yes, that we could have those things. But for right now, we're working with the academy coders to hopefully get their approval so that they will take our grid into consideration when you ask questions to Academy Coding. That's not there yet, but we are working on that. And we are certainly happy to direct you as best we can, but just remember, we're not professional coders. We just see kids and process billing claims.
There was a question before about E&M versus I codes, and I think again, we're not telling you to use absolutely, only E&M or only I. It is really just to say whatever you think is appropriate. And as the coders say, know your insurance companies and know what they would do and plan accordingly. But no, we're not saying, oh, you should absolutely use this or the other.
And each within each individual patient, as you manage patients, things are going to change visit to visit as well. So none of this is intended to give any clear cut, just in the same way that we know that every time we see them, there's something different about that independent exam. This is just to provide, some guidance for what could be appropriate coding levels to support you based on what you did for the patient on that particular day with that diagnosis. So I'm gonna make a quick plug that you are soon going to receive a survey. It's not the annual benchmarking survey that the Socioeconomic Committee always asks, but this one is actually more specific to the amount of care that we're delivering across the United States to essentially manage the appropriate pediatric conditions for our population. So we're writing a policy statement to both support how many pediatric ophthalmologists are needed. That will both allow us to kind of know what workforce needs exist, how to project a little, but also importantly, so that we can be sure that insurance companies appropriately have pediatric ophthalmologists on their panels. So when that insurance company says, oh, they don't need to see you for their ROP follow-up, they can see these other people that are on our panel that don't have any of the expertise that you as a pediatric ophthalmologist has, we will have a policy statement that shows the needed level of expertise for certain conditions. But in that, we also need to know what our capacity is across the country to really manage our pediatric population. So there's going to be questions that are going to come to you in a survey, and there is going to need to be some information gathered either from your administrators or pulled from your practice management systems. And so we laid those questions out so you have a little time to be able to gather that information before you have to answer the survey. But the hope here is that really we'll be able to better support it and have something that is accessible to all of us about the individual role or important role that pediatric ophthalmology plays in the delivery of care in the country. Again, that's separate than the benchmarking survey, which will come out in a few months from now. Benchmarking survey will not require help from the administrators. And again, info@apos.org. Send us anything else that we didn't get to tonight that comes as you begin to use this grid. We're happy to hear from you. We also are looking to try to do a coding webinar involving Kevin Corcoran, ideally over the next few months, but we'll be in touch about that too. Anything else, Heather Hawk?
No, I am saving all of the questions we didn't get to. Some of them are so we can answer them later. So know that it will come back out. Don't worry, we did not forget you. They're just some of them are specific and we want to make sure that we get you the right information.
All right.
Thank you, everybody. This is the beginning. This is not the end. This is a living document. As we say, this is something that is really meant to help and support people, but again, not answer every specific situation per se. But this is the beginning, and thank you, everybody.
Have a good night.
Night, everybody.